I'm Dr. Jeff Donovan. We just finished a webinar on scarring alopecia. I conduct webinars for the public and for physicians throughout the year on various topics in hair loss. This was a free public webinar on scarring alopecia. This time I invited participants to submit questions ahead of time. I wanted to make sure everyone had their questions answered in the order that they were received. And we had enough time to get through 31 really fantastic questions. You'll have the opportunity in a minute to hear the answers to these questions. If there's a specific question you're interested in, be sure to check out the description box below. You'll see the 31 questions listed, and there'll be a timestamp there, and you can fast forward to the specific question that you're interested in. I want to thank everyone for participating this evening. I hope the webinar was helpful, and for those of you who are watching, I hope that these questions and answers will be helpful and informative to you in some manner. And I look forward to seeing you again. And so if you've sent in a question, it's here. And so I will get to it. Even if it repeats, I'm going to repeat it. Sometimes the way a question is phrased is different for different people. And so I will repeat a question or two. Does telogen effluvium ever form scars? Telogen effluvium is a non-scarring hair loss condition that is due to factors that trigger hair loss, like stress, low iron, thyroid problems, medications, diets. So generally speaking, telogen effluvium doesn't form scars. There can be a telogen effluvium in a patient with a scarring alopecia, but the telogen effluvium itself does not form scars. So a patient has said the following. For patients with FFA, do you order hormone levels prior to ordering finasteride or dutasteride? If the levels are drawn, do you refer the patient to an endocrinologist, or do you evaluate the lab results and prescribe accordingly? Do you prescribe finasteride and dutasteride without lab values? And so thank you for this question. The answer is that one does not need to order lab tests before prescribing finasteride and dutasteride according to the package labeling or the way we think of these medications. My view is that I do order blood tests for these hormone levels in patients with FFA, frontal fibrosing alopecia. We know that a certain proportion of women with FFA will have androgen deficiency, low androgens, and a proportion of women will have other hormone deficiencies like thyroid abnormalities, possibly early menopause in young women with FFA. And so I consider it important to order hormone tests in women with FFA before starting treatment. If a patient has androgen deficiency, but also has other signs of androgen deficiency, possibly mood alterations, changes in muscle mass, other concerns that go along with androgen deficiency, I might be a little more reluctant to prescribe an anti-androgen like finasteride or dutasteride until we have an endocrinologist review the patient. But some people do have androgen deficiency and lower hormones with age. Many remain relatively asymptomatic, and using finasteride or dutasteride may not be a concern in those individuals. And so I do order blood tests. I don't refer the vast majority of patients to endocrinologists, and there's nothing particularly wrong with ordering, prescribing without these lab tests, but it's my personal preference that we do, because I think we pick up a lot of silent things or things that the patient may not be quite aware of that are helpful to follow. The patient asks, I was diagnosed with LPP a few months back. I was prescribed hydroxychloroquine, which is Plaquenil, 200 milligrams a day, and minoxidil once a day. I was also given steroid injections. On a return visit, there's no sign of inflammation. The individual goes on to say, 2 years ago, I had lichen planus all over my body. 3 doctors said it was the worst case they'd ever seen. I tried prednisone, phototherapy, it did nothing. I started methotrexate and I was on that for 12 months and it cleared the lichen planus and it has not returned. My question is, should I be on methotrexate for my LPP, considering my history? Well, the thing that's so important here is that in this introduction, the individual has said on return visits, there's no sign of inflammation. And so what this is certainly telling me is that the hydroxychloroquine and steroid injections and minoxidil seems to be working so far. Doesn't seem to be inflammation. The next key question is there ongoing hair loss? So even though you and your doctor are not seeing inflammation, the next really important question is, are you still losing hair? Does a picture 3 or 6 months later show that it's actually still getting worse? If it's still getting worse, then we have to go back in the toolbox and look for a second line or a first line agent to try to stop the disease even better. And it could be for an individual who is losing more hair that methotrexate could be helpful. But if the lichen planopilaris is stopped, there's no inflammation, you're not losing more hair, then it may not be necessary to start a medication like methotrexate if the condition is now quiet. And so I would only use methotrexate if there's evidence that the condition is continuing. So you and your doctor will want to keep a close eye on the hair loss. Is it getting worse? Follow photos, follow examinations. Those things are going to be really helpful. Second question. It seems that LPP and LP initially were activated after being given steroids and anti-inflammatory meds for other issues. Could the LP and LPP be activated by this? The answer is it's hard to know. We don't understand all the factors that are associated with LP activation and LPP. And so it could be that there was other inflammatory issues going on in the body, which we know can go together with LPP. And so it could be that it was a coincidence and the two have sort of evolved at the same time. So it's difficult to say in a situation like this. We do think that there may be triggers, environmental triggers, other internal triggers that may activate LPP in some people, but we don't have enough good research yet for these. And so just as an aside, the current way we think scarring alopecia has come about is that we think that there's some predisposing factor. We call this step 1, and there's 4 steps. We think there's some kind of predisposing factor that a person has, either they're born with or they have early on in life, that predisposes them to develop a scarring alopecia. And then there's some triggering factor that they experience down the road. Then they get inflammation in the scalp, and then they get the scarring alopecia, the loss of the stem cells and the fibrosis. And so in step 1, we think that some of these predisposing factors may be some metabolic conditions that develop in the skin and the way that the signaling pathways of the immune system go on in the skin. There could be genes, there could be hormonal issues, there could be viruses, there could be autoimmune conditions, there could be dietary issues that predispose us to develop scarring alopecia. Again, we don't fully understand all of these issues, but we think that there may be these predisposing factors. And even though you have those predisposing factors, you may never get scarring alopecia, but some people do. And it's thought that maybe people develop scarring alopecia because of exposure to some of these environmental factors. Again, this may not be relevant for all people, but there's considerations like trauma, cosmetics, ultraviolet radiation, allergens, stress, metals, medications, infections. All of these things have a little bit of evidence in some situations or some scenarios as being triggering factors for some people's scarring alopecia. And so we don't have all the pieces of the puzzle yet together, but it does seem that there are these factors that are relevant to the development of scarring alopecia. And so your question is a good one, because maybe there were factors that led to an increased risk to develop LPP. A patient says, I was diagnosed with LPP and alopecia areata nearly a year ago. I'm under a dermatologist. So far, I've only been given Elocon cream for about 6 weeks. I'm still getting itchy. Thankfully, no further hair loss than the small area on the hairline. I think that was all the individual said. So thanks for submitting this. When a patient says, I don't have any more hair loss, I'm always very encouraged, but the thing to remember is we really need to observe over a long period of time. Someone who says to me, I've had no hair loss for the last 3 months, that's great. But what's really, really important to me is, have you had any hair loss over the last year, 18 months, 2 years? If a person has had 0 hair loss over 2 years, I'm feeling pretty rest assured that this is probably quiet. But if a person has had no hair loss over 3 months, I don't rest assured that it's quiet. I'm certainly encouraged and very happy that it seems to be quiet, but sometimes scarring alopecia moves very, very slowly. And the fact that this patient is still getting itchy would be a concern and would need to be explored why the itching is occurring. Is it the scarring alopecia? Is it dandruff or seborrheic dermatitis? But the fact that there's itching is a concern. Question 6, what's meant by burnt out scarring alopecia? Well, burnt out scarring alopecia is a very specific term. It's a term that means the scarring alopecia is done. It is quiet. And it is so quiet that one can stop medications and it does not activate. One can stop medications and there's no more hair loss, there's no more itching, it's done. And so it's a very special term. And so when I think about burnt out scarring alopecia, there's 14 questions that I ask a patient to allow me to determine, is it truly burnt out? For example, sometimes I am referred a patient and the patient really wants to go for a hair transplant. And the hair transplant doctor says to me, can you tell me if the patient has burnt out scarring alopecia? Because if they do, they might be a candidate for surgery. If they don't, we have to delay the surgery. They're not yet ready to go. And so I might first ask, do you use any medications in the last 2 years to treat your scarring alopecia? If a person is currently treating their scarring alopecia with medications, we can't determine if it's truly burnt out. It might be inactive, but it might be inactive only because we're still using medications. And so if a person is not using any more medications for 2 years, then we move on to the next set of questions. I won't go through these in detail, but we want to know if we take a good series of photos and we compare them to a good series of photos 2 years ago, are they identical? And so when a patient comes in to see me, I will often say, I don't know if your scarring alopecia is burnt out, but I'm going to take a lot of photos. I'm going to take 30, 40, 50, 60 photos. And I'm going to see you again, maybe in a year or 2 years, depending on my feeling about the situation or where the patient lives. But I'm going to ideally want to do those photos again in 2 years. And when I lay those photos out on the desk or I put them out on the screen, if those photos look absolutely identical 2 years later, that's a good chance this is burnt out scarring alopecia. If the photo in 2 years shows, it's a little bit less here, a little bit less here, it's moved back a little here, that's not burnt out scarring alopecia. So burnt out scarring alopecia means the condition is inactive, it's quiet, the patient is off medications, they don't need medications, it is done. And I ask other questions. Does the patient feel there's less hair? Is the eyebrows less? Is the eyelashes less? Do you have to occasionally put a dab of clobetasol to keep things from flaring? If a patient is using clobetasol once a month or twice a month, because it acts up every now and then, that's not burnt out scarring alopecia. It might be fairly quiet scarring alopecia, but it's not truly burnt out scarring alopecia. And so we have these questions that allow us to really get a sense, is it truly burnt out scarring alopecia? And we do use this word a little too liberally, and it's a very special term, burnt out scarring alopecia. It means the condition is done, and we can, if it's truly burnt out, we can stop medications. We can see the patient in 2 years or a year and not worry they're going to lose more hair. If it's not burnt out, we might need to see the patient again in 3 months or 6 months or 4 months or 8 months. They might need medications. We're not going to, say this is done. So there's these series of questions that we ask to get a sense if it's burnt out or not. Someone's asked, my biopsy says I have mild inflammation. What does this mean? Well, it means that when the pathologist looks under the scalp at the biopsy, they see that there's mild inflammation. There's just a little bit of inflammatory cells. You might recall that histology slide of lichen planopilaris, where you saw all those little blue dots. If there's just a little bit of those blue dots, a few of those blue dots, that's mild inflammation. If there's moderate inflammation or severe inflammation, the pathologist will comment on this. We don't really have a great idea about what it means if someone has mild or moderate, but the thinking is that if someone has severe inflammation, that maybe we need to be a little more aggressive with treatment. If someone has severe inflammation on biopsy, it's pretty unlikely that clobetasol lotion alone is going to stop the disease. If someone has mild inflammation, it might, we might need clobetasol lotion and some steroid injections, and we might want to start, an oral treatment like hydroxychloroquine. But if someone has mild inflammation, there's going to be some patients in that group that do really well with minimal treatments. And so that's what the pathologist is commenting on. Someone has asked, how often does LPP and FFA occur in the same patient? The answer is probably in about 15 to 25% of patients with FFA will also have LPP. And so whenever I see a patient with frontal fibrosing alopecia, we want to look further back in the mid-scalp to see if there's scarring alopecia occurring there. And if there is, then that patient has FFA and LPP. So they commonly do occur together, but not every patient with FFA has LPP. And so someone has asked, is LPP the same as FFA? The answer is it's not. LPP is slightly different. It is currently viewed that FFA is a subtype of LPP. And so you will hear that FFA is just a type of LPP. But LPP is a scarring alopecia that typically affects the middle of the scalp, as we've seen before, whereas FFA is a type of scarring alopecia that typically affects the front of the scalp, the sides of the scalp in the initial stages. And so patients can have both. If it's predominantly affecting the front and the eyebrows, a term like FFA is appropriate. If the scarring alopecia is more affecting the back of the scalp, and a biopsy shows it's lichen planopilaris, or up close trichoscopy shows it's LPP, that term would be the preferred term over frontal fibrosing alopecia. And this is an image of FFA. What type of environmental factors are relevant for scarring alopecia? Well, we've seen a little bit of this earlier, and that is that we don't know all the environmental factors, but these are the things that are being studied. Do certain infections increase the risk of scarring alopecia? Diet, trauma, cosmetics. There's been quite an interest in frontal fibrosing alopecia and looking at whether certain types of moisturizers are increasing the risk of FFA. We do not have all the answers yet, so we do not know, but it's an area of active study. What about pollution? What about ultraviolet radiation? Clearly, there's things in 1990, 2000, 2010, 2020 that were not present in the 30s, 40s, 50s, and 60s. And those environmental factors are probably very, very relevant to some of these scarring alopecias like FFA. And so there's a lot of intensive research to understand which one of these environmental factors, or which of these environmental factors are relevant in scarring alopecia like FFA? Allergens might be relevant. We are gaining a bit of evidence lately that maybe some patients with lichen planopilaris and FFA have allergies to the shampoos and shampoo ingredients, like fragrance, like other ingredients. We don't know the full answer. We don't know if this is relevant in all patients with FFA and LPP, but some patients with LPP and FFA will find that their scalp feels better, looks better, if they switch to a hypoallergenic shampoo. And so it's difficult yet, with the limited amount of research that we have, to say to every patient with LPP and FFA that you should switch to a hypoallergenic shampoo. We don't know that yet confidently, but that is where the field is moving towards in terms of understanding the role of allergens, understanding the role of allergy cells in the skin, like mast cells, and a movement towards using anti-allergy medications like antihistamines to treat lichen planopilaris and FFA and other scarring alopecias as well. So allergens may have a role. More research is needed. Does stress play a role? Probably does. Again, don't have a great sense of the role of stress, but patient scalp certainly does flare under intense stress. Do certain metals play a role? We don't know yet. There's a lot of interest looking at whether metals like titanium get down in hair follicles and cause inflammation. Some patients, as we'll see in a minute, have asked this question on this evening's webinar. It's very hypothetical at the present time. We do not know. And so should we all be avoiding cosmetics and sunscreens with these ingredients? We don't know. It's premature to say. It may not be relevant at all. And so these are things that are the subject of ongoing research. And we'll see in just a minute some medications that might be relevant to scarring alopecia. I have had LPP for a year, and thankfully it's not got worse. So far, I've only used a steroid cream. Could this be it, or am I being too optimistic? Thanks for this question. The answer is that there are a proportion of patients with lichen planopilaris who only need to use a steroid cream and the disease will stop. That is not everyone. That would be a minority of patients, but there are some patients where the disease can stop. And so the most important thing in a situation like this is to follow photographs over time of different areas of the scalp, have a physician review areas of the scalp for signs of inflammation and signs of disease activity. What you want to make sure in a situation like this is, does the steroid cream take away the itching and the burning? And so it feels a lot better, but the disease is still progressing underneath. It's still causing slow hair loss. That's the one thing you would want to make sure is not happening in conjunction with your hair specialist. Is the risk of rosacea increased in FFA? Well, the answer is it is. It's increased anywhere from 2 to 3 or 4-fold. Rosacea is an inflammatory condition where there's redness that occurs on the face. And so rosacea is certainly increased in FFA, and a lot of good research is being done into why that's occurring. And is rosacea occurring in FFA the same type of rosacea that's occurring in the general population? Is it exactly the same? Is it treated exactly the same? But the answer is rosacea is increased. Someone asks, I have CCCA and fibroids. Is there a known risk of fibroids in CCCA? And so that answer is yes. The 3 disease associations we reviewed earlier are fibroids and breast cancer and diabetes. And there is an increased risk of fibroids, anywhere from about 5-fold increased risk of developing uterine fibroids in women with CCCA. So a really important association, and some great work that's coming out of the US. Can LPP be caused by medications? Someone has asked. And the answer is yes. There are some medications that are being studied. Again, these are generally case reports. And what that means is a rare situation occurs where a patient is on one of these medications and they develop LPP and someone reports it to either a medical journal or to a governing drug agency. But most of these medications are not associated with LPP. It's just a rare one-off event. And it seems to be an uncommon phenomenon, but there are some medications that have been linked to LPP. And so when someone has LPP, it's very important that one understands the medications that a person is on when they were started. What's the minimum time between 2 sessions of injections in FFA? So steroid injections are a type of a treatment which are administered for many scarring alopecias. In FFA, it's administered to the frontal hairline, sometimes in the eyebrows as well. The minimum time really depends on the dose that the doctor is using and the degree of atrophy or thinning that the patient has, how fast it's moving, and whether the person is getting any side effects. And so generally, I will, if we decide together to do injections, I will see a patient back in 3 months. And in 3 months, I will determine, have they developed any indentations where I injected? If they have, we're going to put a pause and we might inject some saline or salt water to get the indentations to come back up. But if a person is getting indentations and their scalp is more sensitive, we're not going to go to every 2 months. We're not going to go to every month, that's for sure. But if a person comes back in 3 months and it's really helping, no indentations, no atrophy, we can move it up to sort of every 2 months. And so it really depends on the patient. In FFA, the disease itself causes thinning of the skin, veins become more visible, the skin becomes thinner. The disease itself can do that. Topical steroids and steroid injections can also do that. And so when we do steroid injections, we constantly have to be thinking about, is my steroid injections causing any more harm than good? And so that always has to be kept in mind. So the minimum time, would be 8 weeks, but that's only in some patients. In other patients, 3 months or 4 months may be more appropriate. And in some patients, steroid injections might not be a good idea if they're developing worsening indentations or atrophy, or it just doesn't seem to be effective. Can LPP affect the whole scalp? It certainly can. Lichen planopilaris often starts in that central zone, as we saw, but there is a diffuse form of LPP which affects the entire scalp, and it can look very similar to dandruff or seborrheic dermatitis or psoriasis. I have folliculitis decalvans and my doctor wants to give me steroid injections. Won't it make the condition worse if it's caused by an infection? Folliculitis decalvans is a scarring alopecia associated with bacteria known as Staphylococcus aureus and other bacteria. And there is some concern by some people that if there's bacteria in the scalp and you inject steroids to calm down the immune system, won't the bacteria just grow because the immune system isn't there to attack the bacteria? Well, what we know is that doesn't occur in most patients, and that steroid injections can be highly effective for many patients with folliculitis decalvans, not alone, but in combination with other treatments like antibiotics, skin cleansers, and other things that kill the Staphylococcus aureus. But steroid injections can be very helpful for many patients with folliculitis decalvans. Many patients with folliculitis decalvans have terrible burning and pain. It's sore, it's tender. They don't sleep well. They don't function well at work. They can't put on a hat. They can't ride a motorbike if they ride a motorbike with a motorcycle helmet because it hurts. Steroid injections give them some peace back, and they can be life-changing. So absolutely, it's an option. I have CCCA. Should I do doxycycline or steroid injections? Well, thanks for this question. This is a really nice question because it really brings us back to the concept that sometimes we do need combination treatments. I really do, in my practice, like to start treatments one at a time to get a really good sense of how each one is working. Not all physicians do that, and that's okay. That's a personal preference. But if a person is more comfortable with steroid injections and the side effects of things, then perhaps start steroid injections. If it's discovered in 3 months or 6 months that, the hair loss is still continuing, I'm doing these injections, but it's getting worse, then it might be appropriate to have a discussion with the physician about whether starting something like doxycycline would be a good idea. Should we continue the steroid injections and add the doxycycline? Should we stop the steroid injections and just start the doxycycline by itself? These are all questions that need to be discussed on a sort of a case-by-case basis, but often we use combination treatments. And again, this was the algorithm of first line, second line, and third line treatments. And you can see that steroid injections are in the first line group, and so is oral doxycycline, which is an antibiotic that reduces inflammation. We're not using this antibiotic because there's bacteria in CCCA. We're using it because it reduces inflammation. What supplement should a person take with scarring alopecia? Well, the short answer is that a patient should take a supplement that they need. And so the next question is, what supplement do you need? So if a patient has low iron or low vitamin D or low B12, then it's a good idea to take vitamin D, B12, and iron. How do we determine if a patient has low iron or low vitamin D or low B12? With blood tests. And so I think that the answer to this question really revolves around, if something is low or deficient, then these are certainly the supplements that should be addressed. We don't have a good sense yet on some of the other supplements and their role in scarring alopecia. Certainly these are areas for future studies, something that I'm very interested in. What is the role of turmeric or curcumin in scarring alopecia? What are the role of other things, other herbs, other vitamins? We just don't know yet. And so my main concern is that if someone's deficient in something, we need to replace it, and the other things need more study. Someone has asked, I'd like to have a hair transplant, but I read mixed things. Is it safe for a person with scarring alopecia? I have lichen planopilaris. And so this is a really great question. The most important sentence here is, it's safe for a person with scarring alopecia. I think more people need to ask that question. Hair transplants can work really, really well for scarring alopecia, provided it's completely inactive, provided it's burnt out. And we've reviewed those criteria earlier. What constitutes burnt out scarring alopecia? And those are on the website as well. But I think it's really, really important that anyone who's going to go and consider a hair transplant, that they have burnt out scarring alopecia. So if their scalp's still red, it's still itchy, they're still using medications, and they're just tired of these medications and they would like to have a hair transplant, it's not a good idea, that's for sure. The disease can sometimes worsen. The scarring alopecia can sometimes not take. And so if there's any indication that a scarring alopecia is still active, then a hair transplant is not a good idea. But if you and your doctor feel this is truly burnt out scarring alopecia, it could be a very good option to consider. How likely is it that a topical steroid will stop my LPP and that's all I will need? And so this is a repeat of one of the questions coming from another individual, maybe the same individual. And so there are some patients that they only need to use a topical steroid. There's no doubt about that. There are some very mild forms of LPP. There are some forms of LPP that announce themselves, they last 3, 4, 6 months, and they kind of die down and they go away. I think there's a bit of a myth or a misconception that scarring alopecias last a year or two and then they all go away. That's just the natural life cycle. That is a myth. That is a misconception. There certainly are some scarring alopecias that run a milder course, but not all scarring alopecias run a milder course. And so is that all you need? Well, you follow pictures very carefully, you follow photographs, you follow trichoscopy at your dermatology visits to look at the activity. And if it's not moving, there's no more hair loss, there's a good chance it's becoming very quiet. Does finasteride cause breast cancer? I've been recommended it for my FFA. Thanks for this question. It's a really good one. It's a really important one. And questions like this really do need to be taken on a case-by-case basis. There's no doubt about that. There is no one answer. But when we look at all the evidence, there is no evidence that finasteride and dutasteride cause breast cancer in women. We do not have that evidence. Finasteride and dutasteride have best been studied in men because finasteride and dutasteride are used for male pattern hair loss. There is about 8 or 9 studies that have been done in men looking at the risk of breast cancer in men from these drugs. And men do develop breast cancer. It's not common, but they do develop breast cancer. Of those 8 or 9 studies, 8 of them have suggested that there's not really an increased risk of breast cancer in males that are using finasteride. There has been one study that suggested that there was an increased risk. But more recent studies, good studies, have suggested that there doesn't appear to be an increased risk in men. The best we can do is extrapolate this data to women. That's the best we can do in the current day. And the current belief is that for women at low risk, there may not be an increased risk. Again, that's being studied. But for women at high risk of breast cancer, we still don't know for sure. So if someone has a sister with breast cancer, if someone themselves has breast cancer, if someone has a mother and an aunt and a sister with breast cancer, their risk may be different than another patient who has no family members with breast cancer. And so an individual at low risk for breast cancer to begin with, there is no real good evidence in the present day to suggest that there's an increased risk of breast cancer by using finasteride or dutasteride for FFA. That still needs ongoing study. The second point that's really relevant here is there is another anti-androgen that's commonly used in women that has been studied fairly well, and that's spironolactone. Spironolactone is different than finasteride and dutasteride, but it's also an anti-androgen. And studies to date have suggested in 3 good studies that there's no increased risk of breast cancer in women who use spironolactone. And these studies have been done in women. And there's a recent study looking at spironolactone use in women who have breast cancer to begin with. And those studies showed that women with breast cancer did not have their breast cancer return at any different rate. We call that a recurrence. They didn't have any higher rate of recurrence than women who were not using spironolactone. And so when you take all of this together, it suggests that, so far, the data would suggest that in women at low risk, there should not be a significant increased risk of breast cancer. In women at high risk, in women with family members, in women with other factors that need to be discussed case by case, there may be a difference of opinion. And so really, really great question, but for women at low risk, doesn't appear to be an increased risk of cancer. Are there any over-the-counter products that help scarring alopecia? Certainly there are some over-the-counter iron supplements and vitamin D supplements that, if one is low, may have some benefit. If someone is low in vitamin D, which is an increased risk in some of these scarring alopecias. Supplementing with vitamin D to get back to normal levels is important. We still don't have a lot of great evidence that if you go from low vitamin D right up to normal vitamin D, that you help stop your scarring alopecia. We don't have that evidence yet. It sounds good, but we don't have that evidence. But certainly if one is low, vitamin D should be replenished. The other over-the-counter products that can be considered in discussion with a physician or other specialists would be the antihistamines. Many of these antihistamines are over-the-counter, like cetirizine and others, go by names like Zyrtec, Reactine, Claritin. Some of these are showing evidence of being helpful in some of these scarring alopecias. So there are some over-the-counter products that could help. I had a biopsy that showed I have scarring alopecia. Well, I need to get another one to see if it's dormant. It's a great question. The answer, in my opinion, is no. That we evaluate if scarring alopecia is dormant by listening to the patient. How much itching do they have? How much burning do they have? Do they think they're still losing hair? And then comparing photos. And so if I take 20 or 30 photos, and 6 months down the road, I take 20 or 30 photos again, and 6 months down the road, I take 20 or 30 photos again. If those photos keep looking the exact same, there's not even one hair out of place, that scarring alopecia is pretty quiet. I'm not going to do a biopsy. I don't care what the biopsy shows. The scarring alopecia is quiet. And so we really rely a lot more on the clinical features. We rely a lot more on the patient story and the pictures. These are really, really important. And so pictures are really, really important in scarring alopecia. For a patient with LPP, what antibiotics, if any, would you suggest? And should I be taking high doses of vitamin D? So LPP is not caused by an infection that hangs around in most people. In other words, we don't use antibiotics in LPP to treat an infection. There are antibiotics that happen to be able to stop inflammation, like doxycycline, minoxidil, tetracycline. And so these are sometimes used as treatment, but they're not used because we want to kill bacteria. They are used because they stop inflammation. And should I be taking high doses of vitamin D? Well, if you have low vitamin D levels based on your blood tests, then taking higher doses of vitamin D is a great idea. But if your vitamin D levels are pretty normal to begin with, then taking high doses of vitamin D would not be recommended. And there can be some issues with high doses of vitamin D that go on for years and years without anybody monitoring. But certainly if one is low, taking vitamin D is a very good idea. We have, I think, 31 questions, if I remember correctly. So we're almost there. And I'm just looking at the time. Can you put or use hair dye? And is there a particular chemical to avoid or look out for? So we don't have any good evidence yet that hair dyes in patients with lichen planopilaris, FFA, CCCA, really exacerbate or cause flares of the disease for the vast majority of patients. Now, 1%, 2% of the entire world has hair dye allergies. And so can a patient with lichen planopilaris have a hair dye allergy? Absolutely. 1 out of every 100 patients with LPP is going to have a hair dye allergy, just by statistics. But I am not usually concerned about a patient using a hair dye. However, I need to know their story. If a patient uses a hair dye and after the hair dye, they find my scalp burns and it itches and the next week is just horrible, the redness intensifies, its shedding acts up, then we may need to remove the hair dye or change the hair dye or do something different. But for the vast majority of patients, hair dyes are okay. And there is an occasional patient whereby getting a hair dye helps the scalp feel better. And the reasons for that aren't clear, but it's certainly not always bad, but we do have to watch closely. Sometimes a patient does have a little bit of a reaction. We might use a topical corticosteroid the night before they go in to get their hair dyed. Sometimes we'll even use it the day of at the salon, depending on the patient, to try to block any irritation that the hair dye or the hair salon visit will create. But for most patients, it is okay. Does LPP typically improve if other health issues like the gut or nutrition or thyroid or stress are brought under control? In some patients, yes, but not in all patients. So I think that's really important. There certainly are some mild forms of LPP and FFA, mildly inflammatory forms that changes in gut health and nutrition can have some benefit, but not in more active and moderately severe cases. Stress, yes, there are many patients that find that when they get stressed, their scalp flares. And so if that stress can be brought under control, the scalp will feel better. These are areas that are really in their infancy in scarring alopecia, understanding the role of stress, the role of the gut. We know it's very important. We just don't know how to manipulate it in a way that's beneficial. Other fields are beating us to it. And one of the fields is the rheumatology field. And, for example, we know that some autoimmune diseases like rheumatoid arthritis can be dramatically improved if stress is brought under control. And there's lots of fantastic studies in other fields of medicine looking at stress control, meditation, Tai Chi, mindfulness. We don't have those studies in our field, but hopefully we will. Other fields have really done wonderful work looking at the role of the gut. We know the gut is changed in patients with lichen planopilaris, FFA, these scarring alopecias, these autoimmune conditions. We know that some of these patients have different gut microbacteria and the microbiome is changed. We just don't know what to do with this information yet, but stay tuned, those pieces of information are coming. Does an autoimmune diet help? Do you need to cut out dairy and gluten? The autoimmune diet is a term that is loosely thrown out. And the answer is we do not know what diet helps, and we do not know what patient that diet will help. I'm always okay with patients considering dietary changes, especially when they're for the better. We have to be very, very careful to back that up by evidence. But I'm okay with a patient making a change that is in general healthier, because there are some patients it benefits. What we have to be careful about is there definitely are some patients that it doesn't benefit. And so we have to be careful that we, promise patients that if you just change to this diet or that diet, that you'll be okay and everything will resolve. It doesn't happen that way in everybody. But I'm a big believer in the role of diet to affect inflammation. But my view is that it's popularized in many ways without a lot of great evidence in our scarring alopecia field. And so we're in desperate need of good studies that can back this up. Are there patients that benefit from stopping dairy and gluten? Yes. Are there patients that stop dairy and gluten and find there's no change whatsoever? Yes, there are. And so we need study in this field. Is titanium dioxide the culprit to hair loss? Titanium dioxide is an ingredient in sunscreens. Zinc oxide is often a mineral agent in sunscreens. There has been some thought that maybe these little minerals get down in the hair follicles, plug them up and cause inflammation. We don't know yet. The cosmetics industry has changed a lot over the years to making these particles smaller and smaller and smaller. such that they can get down in the hair follicle. It's too early to really say if we should all be avoiding these. My thought is that probably not. And so we have to make sure that we are using sunscreens appropriately, and there's not enough evidence that's convincing that these are the culprit quite yet. What does inflammation mean? Is it bad for you? Well, there's lots of types of inflammation, and there's good inflammation, bad inflammation. If you scrape your knee on the sidewalk, you're going to get inflammation, but that's a wonderful inflammation to come in and clean up bacteria and make sure you don't get infected and make sure things heal. So some inflammation is really great. And some parts of the body have lots of inflammation. If you look in your gut, the healthiest of healthiest guts has lots of little inflammation going on in different areas. That's just what it means to be a gut. But there is inflammation occurring in this scarring alopecia that's not good and not helpful. And this inflammation is consisting of inflammatory cells that have moved into the skin for the purpose of attacking the hair. And so that type of inflammation is harmful, and it is bad in that sense. And so the purpose of these treatments is to tell that inflammation to either go away, leave the skin, or to stop attacking the hair. Do you recommend PRP or light therapy? These are, in some cases, second or third line agents. I don't think PRP is a first line agent for any scarring alopecia that I treat. There is some physician dependent views on this, of course. If a clinic is a PRP clinic, then they offer PRP, but it certainly is an option. It doesn't help everyone, and it may be less effective than some of the other first line treatments. And so it is true that PRP is natural, it's one's own blood, but we have to evaluate its effectiveness. And it may not stand up anywhere near as close to some of the other first line agents. And so that always has to be kept in mind. PRP may be a second line or a third line agent, depending on the scarring alopecia. What about shampoos? Are there any that you recommend? Well, I recommend shampoos if there is a problem with the current shampoo. And so in order for me to change a person's shampoo, I have to be convinced that their current shampoo is a problem. So there are patients with scarring alopecia that have seborrheic dermatitis, which is a cousin of dandruff. You get redness and flaking and itchiness in the scalp. These are kind of the same symptoms as scarring alopecia for some patients. And so if someone has seborrheic dermatitis, then an anti-dandruff shampoo may be appropriate. If someone has LPP or FFA, and we are kind of wondering about a shampoo allergy, it's kind of something we have not proven, but we're kind of wondering about it. There's sometimes some rashes on the ears, sometimes on the neck, sometimes some facial rashes, back of the neck. They had an allergy to a cream they used 5 years ago when visiting a hotel on a vacation, and so they're wondering about allergies. Sometimes we will change to a hypoallergenic shampoo, and there's about 5 hypoallergenic shampoos that exist. But I'm only going to change a shampoo if I feel that the current shampoo doesn't do the trick. I'm not a believer in shampoos just because another shampoo helps scarring alopecia. No, if there's seborrheic dermatitis, if there's allergy, then we may switch the shampoo. Final question, and then there's some questions waiting. I was prescribed a JAK inhibitor cream for my frontal fibrosing alopecia. I know it's newly FDA approved for alopecia areata. Do you know anything about the efficacy for cicatricial alopecia? So thanks for this question. It's important to know that these JAK inhibitor creams are not FDA approved for alopecia areata. We use them off-label for alopecia areata, but they're not FDA approved. So that's important to be aware of. One of the JAK inhibitors got approved for eczema. It's a cream, ruxolitinib cream. It just got approved in the US last week. But they're not approved for alopecia areata. They're not approved for scarring alopecia, but we do use them off-label, meaning a pharmacy, a compounding pharmacy, can sometimes make these JAK inhibitors up, like tofacitinib or ruxolitinib as a cream, and they can be helpful for some patients with FFA. And so, and other scarring alopecias like lichen planopilaris. So sometimes we will use topical steroids first. We will use topical non-steroids like pimecrolimus or tacrolimus. And then if the patient is comfortable going on to a systemic or a pill to control the scarring alopecia, sometimes that's a discussion. Sometimes the discussion is any more topical options before we go on. And the answer is we do. We have topical tofacitinib or a topical JAK inhibitor. And so sometimes we do bring on board this topical JAK inhibitor for various reasons. Sometimes a patient uses 3, a steroid, a pimecrolimus, and a JAK inhibitor. Monday they use one, Tuesday they use the other, Wednesday they use the JAK inhibitor, but they are off-label, and that means they still can be prescribed, but you just have to be aware they're not FDA approved for scarring alopecia. But there's a lot of intensive research into these JAK inhibitors, and so we'll be hearing a lot more about them in scarring alopecia